In this video, we'll discuss about surveillance. What is surveillance? Surveillance is an ongoing systematic collection, analysis, and interpretation of health data. So, ongoing systematic collection, analysis, and interpretation of health data essential to the planning, implementation, and evaluation of public health practice. So, planning, implementation, and evaluation of public health practice closely integrated with the timely dissemination of data to those who need to know. So this one, public health practice closely integrated with the timely dissemination of data to those who need to know. It is a responsibility of infection control team. Okay, it is a responsibility of infection control team to decide the time, type, and method of surveillance. So it is a responsibility of infection control team to decide the time, type, and method of surveillance. Collection of appropriate specimens. Collection of appropriate specimens, analyzed the data and plan evidence-based interventions with infection control committee and representatives. Infection control committee and representatives. Surveillance are classified as active surveillance. First one is active surveillance. Proactive surveillance undertaken by hospital infection control team. So surveillance undertaken by hospital infection control team. Second one is passive surveillance, reporting by individuals. Reporting by individuals such as laboratory personals by medical records or reported by physicians. Passive surveillance reporting by individuals. It may be laboratory person by using a medical record or reported by physicians. Third one is targeted surveillance, directed toward a particular site. Okay, directed towards a particular site or place or situation. Okay, so targeted surveillance directed towards a particular site or place or situation. For example, site oriented surveillance. Priority will be monitored frequent infection with significant impact in morbidity, mortality, cost which may be avoidable. So, priorities will be monitored frequent infection with significant impact in mortality, morbidity, cost which may be avoidable. Common priority sites are primary bloodstream infection, surgical site infection, or infection with multi drug resistant bacteria, such an outbreak situation. So common priority site or bloodstream infection, surgical infection, or infection with multi drug resistant bacteria, such an outbreak situation. Next, unit oriented surveillance, where efforts are focused on high risk unit. Here, focusing high risk unit. Example, ICU, operation theater or post operative ward, etc. So unit oriented surveillance, here focusing high risk units like ICU, operation theater or post operative ward, etc. These high risk areas contain immunocompromised individuals, need specific intervention for surveillance. So, this high risk area, ICU, operation theater, post operative wards, these high risk area containing immunocompromised individuals. So, in which needs specific intervention for surveillance. Next, priority oriented surveillance. Priority oriented surveillance undertaken for a specific issue of concern to the facility for UTI infection. UTI infection in inpatient. Okay, UTI infection in patient urinary catheter in long-term care facilities. Long-term care facilities. Priority oriented surveillance undertaken for a specific issue of concern. Example, urinary tract infection in patient urinary catheter in long-term care facilities. Next one is altered organism surveillance. Altered organism surveillance. It is continuous monitoring of that incidents, continuous monitoring incidents of specific organism by the microbiology laboratory. Example, methicillin resistant staphylococcus aureus. So this one we want to do continuous monitoring of that incidence of specific organism by the microbiology laboratory. Next, altered condition surveillance. Altered condition surveillance. Monitoring the incidence of specific clinical condition. So here monitoring the incidence of specific clinical conditions such as infectious diarrhea or tuberculosis or dengue. Is known as altered condition surveillance, monitoring the incidence of specific clinical conditions such as infectious diarrhea, tuberculosis, and dengue. Next, that study, it is the number of cases. Okay, method of surveillance. It is the number of cases in healthcare associated infection in a defined population. It is a number of cases in healthcare associated infection in a defined population either during specified period, okay, even specific period of time, that is known as period prevalence, or at that specific point in time, that is point prevalence. So specific period is known as period prevalence, or at that specific point of the time is known as point prevalence. So what are the advantage? It is a simple, easy and fast. It is also relatively inexpensive and useful when that initiating surveillance program to assess current issue. Okay, so this method advantages simple, easy and fast, inexpensive, also useful when this initiating surveillance program to assess current issue. Then what are the disadvantage? Influenced by duration of patient stay. So influenced by duration of patient stay and the duration of infections. Duration of infection include all infected patient, old and new, which may leads to an overestimation of cases. So disadvantage influenced by duration of patient stay and duration of infection include all infected patient, leading to an overestimation of cases. altered condition surveillance, specific clinical condition such as diarrhea, tuberculosis and dengue. Then method of surveillance advantages: simple, easy and fast. Disadvantage that duration of patient stay and duration of infection, leading to overestimation of cases. Next, incidence, that is longitudinal or continuous. Longitudinal or continuous incidence. It is a number of new cases, healthcare associated infection that occur in defined population during a specific time period. So a number of new cases, healthcare associated infection that occur in defined population during a specific period of time. What are the advantage? More effective in detecting difference in infection rates, to follow trends, to link the risk factor, useful in inter-hospital and inter-unit comparisons. So what are the advantage incidents have? More effective in detecting difference in infection rate, to follow trends, then to link the risk factor, then useful in inter-hospital and inter-unit comparison. Then what are the disadvantage? More labor intensive, time consuming, costly. More labor intensive, time consuming, costly, usually undertaken for high risk units. Next, method of surveillance. First one is active surveillance. Active surveillance carried out daily. Okay, carried out daily by infection control nurses as directed and under the supervision of. So active surveillance carried out daily by infection control nurses as directed and under the supervision of the infection control officers. Then appropriate and relevant data is collected by infection control nurses from clinical ward and microbiology lab. Data collected from clinical ward and microbiology lab. Okay, so infection control nurses collected data from clinical ward and microbiology lab. Next, various way of collecting data. For example, clinical visits. So what are the way? Example, clinical visits. Recorded in unit oriented surveillance in various vulnerable areas, which are ICU, pediatric surgery and post-operative ward. What are the ways we collected data? Through clinical visit in various areas like ICU, pediatric surgery and post-operative wards. Infection control team must visit these area and look for clues. Infection control team must visit these areas and look for clues. A record of fever or other clinical signs consistent with infection. So antimicrobial therapy, laboratory test, review of medical charts, medical records, microbiology report and meeting with clinicians can reveal possibility of healthcare associated infection. Once a hospital associated infection case is identified, once identified, relevant data should be filled. Okay, relevant data should be filled in a pro forma designed by the infection control team. So once hospital associated infection identified means relevant data should be filled by using pro pharma designed by infection control team. Relevant samples. So relevant samples are collected and processed in the hospital infection control laboratory. It is a part of microbiology laboratory. Standard operating procedure for this work should be clearly laid out along with the roles and responsibility of concerned staff. The specimen should be reported as per standard protocols. Okay, specimens should be reported as standard protocols and reported at earliest, because a delay may leads to spread of infection. So earliest report should be reported, otherwise spread of infection may leads to spread of infection. So and may involve a bigger population. The report of investigation are communicated to that concerned unit in charge or doctors. The reports of investigation are communicated by in that unit in charge or doctors and presented before infection control committee. Then a diagnosis of healthcare associated infection, hospital acute infection, standard definition, clinical history, day of admission and day of procedure undertaken, hospital area and what are the staff involvement, then investigation done and specimen microbiology laboratory. So diagnosis of HAI, it includes standard definition and a clinical history, day of administration and procedure undertaken, then hospital area and staff involvement, investigation and microbiology report. This one is the sample pro forma. It having serial number, ward, date of admission, name, age, registration number, then admission, post admission, then day after admission, then site of infection, what are the microorganism, what are the antibiotic sensitivity pattern. In the site of infection, urinary tract, respiratory, like that they have in that form. Then antibiotic given, therapeutic and prophylactic. Then ventilator, urinary catheterization, intravenous line, surgical procedures and others. So the sample pro forma, hospital acute infection, it having that name of the patient, age of the patient, registration numbers, again that diagnosis at that admission, post admission, then day of admission, then site of infection, organism, antibiotic sensitivity pattern, also mentioned that antibiotic given, and the risk factors, the risk factor, the data and the duration of each. Then definition of healthcare associated infection with the clinical criteria. Urinary tract consists of urinary tract consists of fever, frequency, urgency and dysuria, then pyuria. The pyuria more than equal to 3 WBC per high power field of urine. Then gram staining of organism are seen. Urine culture is positive, that is more than equal to 10 to the power of 5 organism per ml. Then diagnosis 5, physician and treatment started. Then the history of catheterization within 7 days of urinary tract infection. Next, surgical site infection, sign and symptoms of surgical site infection, pain, then tenderness, swelling, fever, abscess, fluorant discharge, gram staining and culture positive, infection occurring within 30 days of operative procedure, then diagnosis by operating surgeon and treatment started. Then pneumonia, sign and symptoms of pneumonia: fever, cough with sputum, wheeze, bronchi and crypt. Then physical examination of pneumonia, purulent symptoms, culture uh, positive, sputum, bronchial, aspirate and biopsy are positive, blood culture also positive. Radiological evidence, then significant rise in immunoglobulin, IgM and IgG antibodies. Next, bloodstream infection, sign and symptoms of bloodstream infection: fever, chills, hypotension. Then blood culture positive, then positive antigen antibody test in blood and marker of sepsis. Then diagnosed by physician and treatment started for sepsis. Then gastroenteritis, acute onset of diarrhea with or without fever, vomiting. Enteric pathogen is isolated from stool. Then enteric pathogen is detected by antigen antibody assay on blood and feces. Then example of altered condition surveillance: nursery in tertiary hospitals. This 1 month BSI, UTI, nosocomial pneumonia, SSI, diarrhea, other total prevalence rate containing. Hospital infection control policy may guide which area to be chosen for incidence studies. Then point prevalence study, that infection control team must visit all vulnerable and high risk area like ICU, post operative ward and for once a week, and examine the case sheet of all patient details. This will ensure in capturing maximum data. Then prevalence rate calculated by number of patients who have acute infection divided by total number of patients presented at the time of survey. For example of point prevalence study undertaken in a tertiary care hospital is zone. This including data neonatal ward, ICU 1 and 2, post operative ward. Then the incident studies, the infection control team must visit high risk areas daily and collect data regarding hospital acute infection cases and maintain record of all cases of possible healthcare associated infection, and infection control nurse must prepare. Then line listing, source of infection, visual display chart. Here we can make graphs every month and calculate the attack rate and incidence rate. Example of line listing for a month: the column include serial number, identification of data, diagnosis, risk factor, clinical symptoms, investigation, antibiotic and data discharge. A graphical representation of surveillance activity, the incident study, calculation of prevalence and incidence rate. Prevalence rate is equal to number of infected patient at the time of study divided by number of patient observed at the same time multiplied by 100. Examples: prevalence percentage of nosocomial infection for 100 hospitalized patient, or that prevalence rate is the percentage of urinary tract infection of 100 hospitalized patient, or the prevalence study can be calculated as the number of infected patient at the time of study divided by number of patient exposure at the time multiply into 100. For example, prevalence percentage of UTI for 100 patient with a urinary catheter. To calculate attack rate is equal to number of new infection occurred in a period divided by number of patients observed in the same period, multiply into 100. For example, attack rate percentage of urinary tract infection for 100 hospitalized patient, or this attack rate is equal to number of new infection occurred in a period into number of divided by number of patient exposure in the same period, multiply into 100. For example, attack rate percentage of surgical site infection for 100 operated patients. Then incidence rate can be calculated by number of new nosocomial infection occurred in a period divided by total of patient days for the same period, multiply into 1000. For example, incidence of bloodstream infection for 1000 patient days. Then incidence rate is equal to number of new device associated nosocomial infection in a period divided by total device day for the same period, multiply into 1000. For example, incidence of VAP for vascular associated infection for 1000 ventilations days. Then laboratory surveillance. Infection control nurse must check the report. Infection control nurses must check that report of culture, isolate and antibiogram of specimen received from various vulnerable and high risk areas and microbiology laboratory daily. These cases should be followed up and data should be collected from patient medical chart and treating doctor to find out whether these are hospital acquired infection. So laboratory surveillance nurses check report for culture isolate and antibiogram. They from various vulnerable and high risk areas and microbiology laboratory. These cases should followed up and data should be collected from patient medical chart and treating doctor to find out whether these are hospital acute infection. Infection control nurse must maintain the record of such cases and submit report to infection control officer. So nurses maintain the record of that such cases and submitted report to infection control officer on a periodic basis. Example, comparing antibiotic resistant pattern of gram positive and gram negative bacterium. Antibiotic resistance. Next, investigation of an outbreak. Step 1. Recognition of the outbreak. An increase in number of cases of particular infection or a rise in the prevalence of an organism. Hospital infection control team should visit the site and begin preliminary investigation by developing a case, identifying the site, pathogens and affected population. Hospital infection control team should visit, identify the site, pathogen and affected population. After determining the magnitude of that problem, immediate control measure are required. Okay, immediate control measures are required. General control measures such as isolation of infected case, then hand washing, then strengthening of sterilization and disinfection method, then asepsis advised at the earliest. So what are the things they want to do? Isolation of infected cases, hand washing, then improve that sanitation and disinfection, and asepsis advised as earliest. Next, confirmation of an outbreak should be done by comparing the present rate of occurrence with the endemic rate. What is the step 2? The appropriate department and personnel and the hospital administration should be notified and involved. Type 3, line listening of every cases patient detailed place time of occurrence and infection detail should be developed on the basis of information and data. The suspected causes of outbreak should be formulated and relevant microbiological investigation should be carried out to find out the source of infection. So this one is the line listening. Patient detailed place, time and infection detail should be developed. Then based on that information, okay, based on the information suspect case of outbreak, microbiological investigation. Specific control measures should be advised as soon as the cause of outbreak of identified. Monitoring the further cases and effectiveness of control measures should be done. Report should be prepared for presentation to the infection control committee, departments involved in the outbreak and administration. Next, describing the outbreak. The detailed description include the person, place, time, data, admission, gender, age, etc. And epidemic curve may be plotted. Okay, epidemic curve may be plotted like this. Which is the graphical representation of the distribution of case by time of onset. It should be differentiate between the definite and probable case. The shape of that epidemic curve may suggest a single plot, source, ongoing transmission, and intermittent source. Then control measures and follow up. The aim are to control the current outbreak by interrupting the chain of transmission to prevent the future occurrence of similar outbreak. Then immediate control measure for outbreak management. So next topic is immediate control measures for outbreak management. A type of transmission, that a cross transmission, which is the transmission between individuals. Then suggest the action, patient isolation and barrier free cautions determined by infectious agent or agents. Then hand transmission, improvement in hand washing. Then airborne agent, patient isolation with appropriate ventilation agent. Then pathogen presented in waterborne agent, checking the water supply and all liquid container, use of disposable devices. Then foodborne agent, elimination of food at risk. Then measurement for preventions of hospital acute infection measures, UTI infection, proven effective limit duration of catheter, aseptic technique at insertion, then maintained closed drainage. Then surgical site infection, proven effective surgical technique, clean operating environment. Then staff attire and limiting pre-operative hospital stay. Next, pre-operative showers and local skin preparation of patient, optimal antibiotic prophylaxis, aseptic practice in operating room, surgical wound surveillance. Next one is pneumonia, proven effective ventilator associated aseptic intubation and suctioning, limit duration, non-invasive ventilation, influenza vaccination for staff, then isolation policy, then sterile water for oxygen and aerosol therapy, use sterile water for oxygen and aerosol therapy, then prevention of legionella and aspergillus infection uh, during renovation or constructive activities, proven not effective. Next, digestive decontamination for all patients, changes of ventilator circuit every 48 or 72 hours. Then vascular device infection, proven effective, all catheter. Closed system, limit duration, local skin preparation, aseptic technique at insertion, then removal if infection suspected, then central line surgical, asepsis for insertion, limitation of frequency of dressing change, antibiotic coated catheter for short term, here also proven not effective. Then antimicrobial cream for skin preparation. Next one is benefit of surveillance, measure the quality of patient care and safety. Main aim, measures the quality of patient care and safety, monitoring trend of hospital acute infection, monitoring preventive aspect of hospital infection control program, yearly detection of any impending outbreak, then rational usage of antimicrobial, reducing resistant development and cost, then monitoring and controlling of emerging resistance and changing flora to improve awareness of clinical staff and other healthcare worker. These there is no benefit more than saving lives. So these are the benefit of surveillance.